Well, I think we've had a series of very hands-on examples of how HOBIC information, the assessments, the data, when we have a collection of the individual assessments, can be used in day-to-day practice. So with that, I'm going to ask Carrie Irons, who is our HOBIC lead at ISIS.
First, I just want to thank all the speakers and presenters for coming here and sharing your stories with us. Truly inspirational, and hopefully these can be some stories that we can take back to our workplaces so that we can talk to our colleagues and move forward with our work. So I've been working on the HOBIC project at ISIS since 2007, when we took on the migration and the management of the database from CAMH, where it was residing at that time. We hoped then that giving the HOBIC data a home at ISIS would be able to fulfill some of the intended visions that Dot talked to us about this morning. Well, it's almost 6 years later, and we have come a long way, and Dot indicated that HOBIC was ahead of its time and that its time has come. And I believe this to be true. At ISIS, at least, HOBIC has allowed us to think about the idea of collecting and using real-time data and linking this type of data with the longitudinal data that already is housed at ISIS. It's allowed us to think about the importance of cross-sectoral information and how this information can be used to inform clinicians and practitioners, policymakers, and also healthcare planners. And it's also allowed us to think more about integrating data about nurse experiences and patient experiences with the mainly physician-based data that we have at ISIS. HOBIC is the only population-based data of this kind. In Ontario, it's very innovative, and we are starting to use it, as you saw this morning, to and link to our other data sets. So from my own perspective, and I hope yours as well, I believe that we've achieved the objectives that we set out for today. And through the discussion, I think we've demonstrated the value of HOBIC in acute care as it stands today. So we have a real-time data collection that dates back to 2006 with almost 6,500 patients per month across sectors, mainly in acute care at this point. The data are standardized and they're consistent with expanding coverage across the province. This information is being used to advance clinical practice and patient safety, as we have heard about today. And the data are also being used for performance and benchmarking and quality improvements. And we've also heard about this today as well. And the data are also being used for research. And this research can guide improvements in patient care and improvements in our health system overall. So we've also sat together today to talk about HOBIC. And in this room, we have policymakers, we have researchers, and we also have IT and system specialists. We didn't hear from them at all today, but they're here. And we thank you all for being here, because it's very important for you to understand how the information that you are managing is being used. So that's really, really important. We're also finding that a big part of the continuing value of HOBIC is about the discussion, about the engagement, and about the collaboration amongst all of us. And we've spent more time this year, particularly Peggy, Ian, and Penny, talking with you and your colleagues and connecting some of the other users to better understand how we can all work together to improve your experiences and how we can make the information within HOBIC more useful for all of us. So with innovation always comes some bumpy road, as you know. So you have all received the push reports this year, and there were some challenges to begin with, but with more discussion amongst all of us, we're working together to make this process more smooth, and so it's more seamless as we move along. So finally, as we close, we all owe Penny Dinobrega and Ian Purdy, and of course Peggy White, in organizing this day and moving the HOBIC project forward each day. We didn't provide a formal evaluation in your packet, But as always, we'd love to hear from you. So thank you for coming, and we wish you safe travels on your way home today. Thanks.
Okay, we're done, except I'm going to try and answer Rosemary's question. I'm safe, I'm retired. You can say anything when you're retired. HOBIC's budget has essentially been on hold. It's and has not allowed for expansion across a further implementation. It's partly because of the fiscal situation in Ontario, and everybody's budget, when you're funded by the ministry, it's been maintenance at best. We haven't had a budget cut, but we haven't had the expansion in the budget that we require in order to do further implementation. I think it's critical. I think it's critical for HOBIC moving forward in the sense of being useful to the province from a policy perspective, and for the system, for the LHINs to be able to understand what's happening at that bedside and what the state of patient health is as they leave various facilities or are transferred across facilities. So I think it's important. Now, we're preaching to the converted here. Folks in this room have HOBIC, but you know, we're not quite halfway in terms of the acute care hospitals, and we think acute care and home care are two of the linchpins because of inter-eye data that are available in long-term care. And complex continuing care really is being picked up with the acute care hospitals, so that's less of a problem. But I think it's important when encountering folks in the ministry or working with the LHINs to really talk about the value that HOBIC brings and the inability to have comparative data across institutions when some of them don't have HOBIC data to contribute. It limits the work that Walter and Linda are doing in terms of looking at it, and in what you folks are doing at Queen's, but other investigators across the province, by not having access to data from there are a few of the academic health science centers that have it. Hamilton, in a large part thanks to Ruth. Ruth Lee has been a huge promoter of HOBIC in Hamilton, and St. Mike's and their dashboard presentation last year in terms of how you can present data at the unit level and use the picker data as well to help nurses see what's happening, and that's a huge in terms of just quality improvement for the whole unit. But we don't have, London Health Sciences is supposed to be coming on next year, not any longer. 2015 now, okay, 2015. And I don't think Kingston General doesn't have it. Ottawa doesn't have it. Toronto General, Toronto Western. So the very large academic hospitals, we have much better representation with the large community hospitals, where a lot of them are included. But I think we all that are part of HOBIC have to be pushing it all the time around the value for individual patients, for hospitals in terms of their quality improvement, and for better understanding how we can manage some of the more intractable problems that we're facing. So with that message, home safely, and carry on.